I am Dr. Vivek, emergency medicine resident, Amrita Hospital. I will be giving details of a patient who had presented to our ED with RTA. 35-year-old female was rolled into our ED with alleged history of RTA. Our EMTs have assessed the patient inside and they have taken the patient in spine boot and they have given Philadelphia collar and they noticed abnormal mobility in right upper limb, so they have splinted the patient. Our initial 10-second assessment in ED, patient was drowsy, response to pain was there. Her airway is compromised and she is tachypneic with a CRT of 2 seconds. We proceeded with the parallel assessment of primary survey. We are expecting a life-threatening injury which we have to assess at this point of time itself. On parallel assessment, her airway, she is having secretions in oral cavity, blood pooling is present, and she is having abnormal crepitations in both maxillary regions. There is oral bleeding for which we have started him on suctioning, and her breathing is 22 cycles per minute and saturation is 90% with 8 liter of O2 with face mask. And chest movement is bilaterally symmetrical, air entry is bilaterally equal with no crepitations or V's. Circulation, her BP is 130 on 90 millimeters of mercury with a map of 98 with a CRT of 2 seconds. Her all peripheral pulses are present and equal. Disability, her GCS is E2, V2 and M3. Pupils are 2.5 millimeter equally reacting to light. Exposure, temperature is 98 degree Fahrenheit, GRBS is 114 milligram per deciliter. In management part of primary survey, we gave oral suction and we are planning for RSI with 8 size tube and we intubated her and angle of mouth is secured at 20 with cuff pressure of 18 and she was connected to ventilator. Drugs used for intubation is fentanyl, etomidate and rocuronium. Fentanyl of 3 microgram per kg, etomidate of 0.3 milligram per kg and rocuronium of 1 mg per kg. 2 large bore IV cannulas are secured, preferably 18 gauge. And patient is connected to cardiac monitor. Hypothermia is prevented with warm blankets. In adjuncts to primary survey, ABG and ECG is asked at this point of time. ABG showed a pH of 7.35, PCO2 of 44, PO2 of 60 and lactate of 3.3. ECG is showing sinus tachycardia. Cardiac monitors is already connected. E-fast is done at this point of time. It is negative. Foley's catheter was placed and clear urine is drained. Secondary survey. Patient is not having any allergies. She is not on any regular medication. She had her last menstrual cycles 1 week back. Other cycles are 3 on 30 regular cycles. Last meal is 5 hours back. Events leading to this history is patient is an unhelmeted two-wheeler rider. Approximate speed of vehicle is 60 km per hour. Hit against a lorry. And from then she had loss of consciousness is there. There is no episodes of vomiting. There is no episodes of seizure. She is having nosebleed and oral bleed. In examination finding, head to toe examination, she is not pale, no icteric, no cyanosis, no pedal edema. In head, there is multiple abrasions present in both maxillary regions on forehead. There is active bleeding present in oral cavity and nose. And palpable maxillary crepitations are present. Mandible is normal and tongue is in normal position. Log roll was done and to check for C-spine, gibbous and step deformity and other spinal deformities. There is nothing else noted. In systemic examination, we started from chest, abdomen and pelvis. In chest, her right-sided infraclavicular area there is some fullness and clavicle continuity can't be palpated throughout and there is some discontinuity is there with palpable crepitations. But her bilateral breath sounds are present. There is no added sounds, V's or creps. Then there is no reduced air entry or other things. Then in cardiovascular system, her heart sounds are present. S1, S2 is heard. No pericardial or pleural rub and jugular veins are normal. Abdomen and pelvis examination, pelvic compression test and chest compression test were negative. And both femorals are palpable at this point of time. Then in musculoskeletal system examination, already her right upper limb is immobilized with splint, and before that we did a examination where there is bony irregularities present and crepitations are present and bone is exposed with active bleeding, and this is a contaminated wound with mud particles, and rest other limbs are normal. For this wound we have given wash and we have stopped bleeding with compression. At this point of time, with history and clinical examination, our primary impression would be patient had a RTA with the possibility of head injury with airway compromise and right upper limb fracture with the possibility of right clavicle fracture. Multiple facial fractures also a possibility. In investigation, we need to proceed with X-ray trauma series of chest and pelvis, then CT brain with whole spine screening, and X-rays of right upper limb. We start from right arm, forearm and hand. Both AP and lateral view, 2 views are taken. In management part, patient have to be given adequate analgesia. Patient is already on ventilator, and we have given fentanyl as a pre-medication agent. We can use same fentanyl or some other analgesia we can prefer for pain, and TTN tetanus immunoglobulin is given. Since it is an open contaminated wound, we prefer superadded tetanus immunoglobulin also, and tranexamic acid is given as 1 gram stat, which is given in 100 ml NS over 20 minutes, and we are planning to give another 1 gram over next 24 hours. Then we are planning to start triple antibiotics since it is an open contaminated wound, preferably cefuroxime, metronidazole and amikacin. And we tried to mobilize the patient for CT, and CT is taken. CT showed a right frontal SDH with there is multiple facial bone fracture with maxillary fractures and hemosinuses, and pneumocephalus is also seen. Then in X-rays, her chest X-ray is having a right clavicle fracture with then her right upper limb X-ray is having a fracture radius, which is an open fracture. Then after CT, patient was taken back to ER where she had desaturation and hypotension. Patient desaturated till 90% with the BP fall of 90-60, and ABG we took at this point of time. ABG showed a HB fall and repeat E first became positive at this point of time. So repeat E first is positive because of right sided hemothorax. Then MTP we at once we initiated for MTP, and PRBC were issued and we started transfusion after 1 liter of fluid bolus. Antiepileptics were loaded in view of brain finding. Neurosurgery, orthopedics and general surgery consultations were taken, and we proceeded. For right-sided hemothorax, we placed the ICD and 550 ml of clean blood was drained out. In follow-up for the patient, there is no further drain from ICD, and ICD was removed on 3rd day, and repeat ultrasound we did, which was showing repeat ultrasound fast, which we are doing. It is there is no worsening of lesion, and orthopedic consultation was taken, and this fracture was fixed, and patient was discharged in stable condition. So our take-home message would be: if a patient presented with RTA, single fast negative, it is not conclusive. So serial fast monitoring we have to do, and not only hemorrhagic shock can be presented in trauma patient, we have to check for other causes of shock also. So we will conclude this is a case of RTA with mild head injury, hematoma, pneumocephalus and maxillary hemosinuses, right clavicle fracture, right hemothorax and right radius open fracture with the class 4 hemorrhagic shock. Thank you.